All right, I think it's great that we're starting early because I have one practice question. So thank you so much for coming and just looking out at the audience this early. I know you're my people, so it's really fun to be with you. And I think we'll have a good time. What I want to do right before we start is just practice with your clickers. So here's your question, all right? The best feature of the intensive nephrology review course is... and I'm going to read them while I get these going. When the faculty include cartoons of urine, when I time myself between my coffee intake and suppression of ADH, laughing at the faculty who still wear beepers, I wear a beeper, and a full week of enjoying nephrology. So choose your response, and then we'll just see how we do, okay? Wow. I'm going to stop it just so that we can move along, but you'll see how you did. Oh boy, a lot of you are laughing at me for having a beeper. And okay, some of you will enjoy my urine cartoons, so good. All right, so what we're going to do this morning is we're going to take a journey through the nephron, and along the way, I'm going to share a variety of stories, case vignettes, and lots of questions. We'll have about 10 questions to go through, and I hope that this will be a nice review and set you up well for the rest of the week. Now, this is the gyps vulture. There are 3 species of vultures that are quite prevalent or have been prevalent in Asia. And these vultures play a very important role in the sort of the life cycle of the land. And so as an example, although many individuals, for example, I'm going to start with India, are vegetarian, they rely on the vultures for an important thing because they have ox and other work animals. And when those animals die, it would be very typical for the villagers to say, sorry if this is graphic, fillet open the ox and leave it on the road for the vultures to come. And in short order, a swarm of vultures could come and pick apart that ox or cattle, and then it would be clean. There would just be bones, and that would be that. And around 1990, the vulture population plummeted. And because it plays such an important part of the life cycle, suddenly feral dogs were increasing in number, and this was a really big problem in the area, and they could not figure out why the vultures were declining so drastically in population, so they were almost endangered. And this was compounded by the fact that laws prevented you from taking vultures and sacrificing them before they were dead, but the temperature is so high in the region that once the vultures are dead, it's very hard to get to them early to see what happened to them. And people wondered, was this a pesticide? Was it a toxin? Was there something in the animals, perhaps antibiotic use in the animals like gentamicin that could cause a problem? And so this was a really big problem. And then they finally were able to identify some vultures and do a necropsy on them. And this is a picture, and what you're looking at is visceral gout. And visceral gout is how birds express renal failure. And so they then were sort of honing in, maybe there was something that the vultures were eating that was causing them to die. And there were a couple of candidates. And ultimately, they circled in on diclofenac, which, sorry for the pun, happens to be called Voltaren in the U.S. And so they identified diclofenac as the cause. And so what you're looking at here is several gyps vultures that have been given diclofenac, and after they eat it, the uric acid levels, and this is in milligrams per liter, so milligrams per deciliter, which is what we use. So instead of 1,400, it would be 140 All right, so we're seeing very high levels of uric acid before these vultures die. All right, so they hone in on diclofenac. So here's your question, all right. Which of the following is the most likely cause of the decline in GFR from diclofenac in vultures? And this would be assuming the mechanism would be the same as in humans. So the mechanism for diclofenac affecting GFR. And here's your choices. A, efferent arterial vasoconstriction. B, decreased glomerular permeability. C, afferent arterial vasoconstriction. Or D, decreased glomerular surface area. There's no music, so what I'm going to do is when you stop voting, I'm just going to end it. But I could sing. All right, why don't we stop and see how you did? Okay, great. And so most of you got the desired answer, which would have been afferent arterial vasoconstriction. And so let's think a little bit about glomerular pressures and review that as well. Now, I want to do okay. So here's a reminder then. We're going to spend some time thinking about glomerular pressures. This is, I'm writing hydraulic because hydrostatic is which is what you'll see mostly in the literature, refers to like static pressures. And you'll see that it's, but in fact, hydraulic is, I think, a better term because this is flow of blood in the vasculature. And so what you should notice here on the y-axis is the pressure in the various arteries. And every time there's a resistance vessel, the pressure drops down. And so there's a very big drop with the afferent arterial. And then the glomerular capillary pressure here is relatively constant because of the vasoconstriction here of the efferent arterial. And then we get down to the peritubular capillaries. Now, the pressure in the glomerular capillaries is quite different from an ordinary capillary, and you can see that on your right. So the glomerular capillary has pressure way up at, say, about 35 millimeters of mercury, whereas over on the left in the peripheral capillary, much, much lower. And the other thing is that the capillary pressure is fairly constant from the afferent to the efferent side, and that's with the help of the efferent resistance vessel. And then as the pressure is the same, the oncotic pressure rises dramatically as you go along the capillary so that they can have filtration. And this is an idealized image of the glomerular capillary, again with the change in pressure being very little and the change in oncotic pressure rising as there's filtration along that. So what are the determinants of glomerular filtration? There is, of course, and so this is a single nephron GFR, and we use this, we think about all the glomeruli together when we think about our estimated GFR or our true GFR when it's measured. The single nephron GFR is affected by the hydraulic conductivity, by the surface area of the capillary, and of course the difference in pressure and oncotic pressure. Now, the kidney has to maintain filtration over a wide range of perfusion pressures. As you know, it's not every perfusion pressure, so it is possible to get under that mark when the blood pressure is very low. And so what about glomerular autoregulation? We have two strategies. First of all, flow to the glomerulus. And so when flow is reduced, these JG cells, these specialized cells in the afferent arteriole, if flow is reduced, they can be maybe a little plumper, and that will allow a signal cascade that will release renin, or sympathetic nervous system can cause the release of renin, and the net result then will be that renin will be on. And as you know, renin leads to angiotensinogen, to angiotensin 1 and then 2. And angiotensin 2, I think, is underrated. Everybody's always talking about aldosterone. It's not that I don't like aldosterone, but angiotensin 2 is like pretty great. And yes, it's really a potent vasoconstrictor. I mean, it tenses your angios, right? And it also causes retention of sodium throughout the nephron, especially in the proximal tubule, and that'll come into play very soon. And then, as you know, it also helps regulate glomerular filtration by vasoconstricting the efferent more than the afferent arteriole. And then, yes, it does stimulate aldosterone. So glomerular filtration is also affected by tubular flow, so the tubular glomerular feedback. And when flow is reduced, then in the macula densa, then that will also stimulate the release of renin and the cascade we talked about. It's not just my fantasy that the macula densa is right next to the glomerular capillary. Here it is, right next to the glomerular capillary. So I think that picture is very cool. And so low flow can lead to the release of vasodilatory prostaglandins, and that's where the diclofenac story comes in. So that will allow you to release prostaglandins and vasodilate the afferent arteriole at the very time that the systemic circulation is vasoconstricted. So that is what we propose is the cause of toxicity, perhaps with diclofenac. And then high flow can also cause something important. High flow can lead to vasoconstriction of the afferent arteriole, and that may be important in the SGLT2 story. I'll tell you in a minute. And finally, a term that doesn't come into play in clinical medicine, but for some reason is often referred to, and that's glomerular tubular balance. And so that is the notion that when there's a lot of filtration, there's more reabsorption. And that's because the peritubular capillary comes down right next to the proximal tubule, and then you can reabsorb most of what you've filtered. And so this is like a little cartoon of that. You can see more filtration when the oncotic pressure in the peritubular capillary is high. And here's a picture also again showing, if you can see these red blood cells, this is a basement membrane for the proximal tubule. So it's right there and ready to reabsorb. Okay, I went off the deep end now. Let's do more questions, okay? So again, for diclofenac, probably related to prostaglandins. And by the way, this is an ongoing story, even though it was old. Just if any of you happen to read Bird's Life, the July 30th edition said that Cambodia just outlawed diclofenac for their cattle. Okay, or for veterinary use. So here's the next question. A 35-year-old man is evaluated for darkened urine. He's using PrEP, which is pre-exposure prophylaxis for HIV, for several years. On exam, he appeared well with a blood pressure of 116/82 and his heart rate 86. Here's his labs, so you can see sodium 138, potassium is 3, bicarbonate 15, BUN 20, and creatinine 1.6, uric acid's 2.8. We've got a urine here, both dipstick and also a protein to creatinine ratio of 1 with an albumin to creatinine ratio of 250. So here's your question. The most likely cause of the laboratory abnormalities in this patient is the classic distal renal tubular acidosis, proximal renal tubular acidosis, or a type 4 RTA. Okay, I'm going to stop. Great, and most of you recognize the desired answer, which is B, the proximal RTA. And so the issue here, if we look at the data a little bit more, what you're seeing is low potassium, And we're seeing actually a pretty low uric acid for somebody with renal failure. That comes as a surprise, and you know that uric acid is reabsorbed in the proximal tubule. The pH is 5, and that might be a surprise for somebody with renal tubular acidosis. But in the proximal RTA, once you get below a threshold, then you can still make acid urine if you're not dumping bicarbonate. So that's the cause of that. We see glycosuria in this urine as well. And then one more little trick, and that is that the protein to creatinine ratio is 1, suggesting, let's say, 1,000 milligrams per milligram, and the urine albumin is only 250. So there's more than 50% of something else, and we're always taught that that can be Bence-Jones proteins, but it could be tubular proteins as well, like retinol binding protein and beta-2 microglobulin. And so when you see that difference of more than 50% between the two, you should be suspicious of other proteins. Okay, so here's the proximal tubule, and I just love looking at this picture because you can see in it that each cell has a primary cilia, which I'm sure you'll be hearing about a little more when you think about polycystic kidney disease. And so you can see those here, these little cilia sticking out. And then cut here, you can see the lush border of the very increased surface area from the villi. And then this is a close-up with EM here, and you can see that lush border. And then on the basolateral side, totally endowed with lots of mitochondria to do the energy. And so proximal tubule cells depend on lots of energy to do their job. And the problem in this case is that patients are taking a proximal tubular toxin. So tenofovir in the older form is transported, it's filtered and it's also secreted. And it does the secretion as other cations and anions do, organic cations and anions, with this sort of pas de deux coming from the apical membrane, the basolateral side with one transporter, and then the apical side with another transporter. And along the way, if the basolateral transporters are working very quickly, or the apical ones are more sluggish in terms of rate, then the mitochondrial DNA can be affected by these drugs. And so that's what we think is happening here. And remember, proximal tubules play a really big role in quite a few things. First of all, a very big player in reabsorbing sodium. And you know, as here, first of all, the big player is the sodium hydrogen exchanger, NHE3. And so when you filter bicarbonate, then bicarbonate is filtered and can join with a hydrogen. All the while, of course, on the basolateral side, we have sodium potassium ATPase revved up to keep that intracellular sodium very low. And then we have hydrogen excreted into the lumen, binds with bicarbonate. You have carbonic anhydrase on the brush border, and that favors conversion to carbonic acid, CO2 and water. And then you reabsorb the CO2 probably with the CO2 channel, so it's not really diffusion like we might have thought. And then inside the cell, the reverse happens. We put that hydrogen back in the lumen and reclaim the bicarbonate. Now, proximal tubular cells are designed, maybe because of the number of transporters or the endowment of carbonic anhydrase, to reabsorb about 24 milliequivalents per liter of bicarbonate. When you get over that point, then bicarbonate starts to appear in the urine, or if there's a defect, then bicarbonate can appear in the urine. And then when you get under a certain threshold, the distal nephron can do its job. And so in this image, you can see also the many things that are reabsorbed in the proximal tubule. And so as you go along the proximal tubule, almost all the bicarbonate is reclaimed, almost all the amino acids are reclaimed, glucose is reclaimed. The sodium on this line is about the same as the osms, even though there's tons of sodium reabsorbed, it's isoosmotic reabsorption. So that was question 2. proximal tubulopathy, and that is true for the older form of tenofovir, TDF. The newer form of tenofovir, TAF, is not yet available in PrEP. That agent is delivered in a smaller dose. So in the PrEP formulation, it's 300 milligrams per tablet. In the newer formulations, it's only 25 milligrams. So dose-wise, it's much lower, and it doesn't seem to be as good a substrate for the proximal tubular transporters. So in general, the hope is that the newer formulations will not cause tubular damage, will not cause chronic kidney disease as well. But there is a single case report now in the annals from January that does show proximal tubulopathy in a patient taking the TAF formulation. Still, I really like it. I'm happy that my patients will have less toxicity. So speaking of agents that are involved in the treatment of HIV, that's our next question. And so here it is, question 3. A novel agent called cobicistat has been FDA approved. It's in combination pills that include tenofovir. And in mild to moderate renal impairment, this leads to a decline in estimated GFR. This new agent boosts elvitegravir levels, but has been found to decrease estimated GFR. The mechanism of altered GFR is A, proximal tubulopathy, B, organic cation transport inhibition, C, effective arterial vasodilatation, or D, tubular intraluminal obstruction. Okay. All right, let's see how we did. Okay, so kind of a mixed answer now. So let me just go back for a second. Here we go. I just want to show you this picture again. So what you're looking at here is actual GFR with iohexol clearance, okay? And you can see really not too much difference in an individual patient, baseline, dosing, and washout. And here, estimated GFR, baseline, dosing, washout, all right? So this is a drug that affects the estimate, but not the true GFR. So this is a drug that affects the serum creatinine, because that would be the only thing that would change in between baseline and dosing. So it affects the serum creatinine. And the way that it does it, so that's the desired answer I'm going to show you. The way that it does it is actually blocks creatinine secretion. So I just a moment ago showed you tenofovir, which is transported by the organic anion transporters. Tenofovir is an anion, and creatinine is a cation, and so is cobicistat. So what happens is these agents are normally transported. So remember that creatinine is filtered and secreted, and about 10 to 20% is secreted, partly depending on your total amount of creatinine excretion. And when creatinine secretion is blocked, the serum creatinine can go up a little bit without a true decrease in renal function. But you will see a decrease in GFR because we measure creatinine. And this is true not just for cobicistat, which is co-formulated with tenofovir. It's also true for, cimetidine, I'm sure you've heard of, and also trimethoprim, and also a lot of the integrase inhibitors that are used for HIV. And it's important to know if you care for patients with HIV, that increase by 0.1 or 0.2, it's not cumulative. You don't get 0.1 for cobicistat and 0.2 for dolutegravir and 0.2 for something else. You only get it one time because creatinine secretion is either blocked or not, and there's no incremental increase. So if you're taking care of a patient who's receiving these medications, you may see the creatinine go up a teeny bit when they start, 0.1 or 0.2. You know that this is the cause. If you see it go up by more, it's something else. And that's really important to remember so that you don't misattribute the decline in renal function for the drugs. And so it's worth noting that. Okay. This is just a picture of organic cation transport and organic anion transport. All right. So one more question that relates to the proximal tubule as we go down the nephron. A series of new drugs have been developed, and I suspect you'll hear a lot more about this in the conference, for treating diabetes. And this blocks sodium glucose cotransporters in the proximal tubule. What additional finding is observed in patients who take this medication? A, hyperkalemia. B, increased edema. C, weight loss. D, phosphaturia. And E, proximal tubular acidosis. Okay, I'm going to stop. I noticed that about 60 of you were voting, and I think there are more than 60 people here. So here we go. Okay, and so the desired answer was weight loss. Although I suppose that patients could also have phosphate loss, that has not been observed. So remember that, So remember that glucose is normally reabsorbed also in the proximal tubule. And we have two transporters. We have the low affinity, high capacity transporters that are early in the proximal tubule, and this is where the drug targets. And we also have high affinity, low capacity transporters late in the proximal tubule that can clean up a little bit of what has been lost. And so when you block the sodium glucose cotransporter, you'll have losses of sodium and glucose. And so it's been observed in patients taking these drugs that they will actually also enjoy a small weight loss. Of course, that weight loss is akin to taking a weak diuretic, that they're losing a bit of sodium and water as well. And so that has been observed, a small weight loss, that's really volume, and a small decrement in blood pressure. And so that is one factor that's occurring. Now, blood pressure may be a teeny bit better controlled, glucose may be better controlled, and that distal delivery of sodium has also been sort of embraced as the cause for why these drugs might be renoprotective. So here's the idea that with an increase, I'm like sort of looking off into the into the horizon when I imagine this, because I'm not sure I buy into it, but this is what has been said, that because of the increased delivery of sodium and glucose, then that will sort of trigger the tubular glomerular feedback I mentioned earlier. And the idea would be that with that high flow of sodium distally, that will stimulate adenosine release, which will vasoconstrict the afferent arteriole, and by doing so, lower glomerular pressure, and that will protect the nephron, the glomerulus, over time. I'm not sure I believe it. I don't know if you're going to hear more about that later, but that's the idea, that decreased delivery, that increase of sodium delivery will affect glomerular pressure. Okay. Here, we're moving away from the proximal tubule to other questions on the distal portion of the nephron, all right? So here's your next question. A group of students eat at a local restaurant, but they succumb to symptoms of norovirus with nausea and vomiting. Several days later, one student notices presents for ongoing malaise, weakness, and vomiting. She also notes lightheadedness with standing. And here's her laboratory data, which is notable for a bicarbonate of 30 and a potassium of 3, BUN of 34, and creatinine of 1.8. The most likely cause of the hypokalemia is A, a shift of potassium out of cells, B, urinary loss of bicarbonate with bicarbonaturia, C, secondary hyperaldosteronism, and D, potassium loss with emesis. Okay, this has got to be one of my favorite questions. So let's see what you guys thought. Oh, okay. Well, a pretty big range of thoughts on this, and nobody fell for the potassium loss and emesis, so bless you, my friends. Certainly, potassium shift out of cells would not cause a low potassium. And so the question is whether, and actually nobody said E because there is no E. D was potassium loss and emesis. Okay, I'll show you that. So it can't be A because that would cause potassium would have to shift into cells. And so let's look a little closer at B, C, and E. So could there be urinary loss with bicarbonaturia, secondary hyperaldosteronism, or potassium loss with emesis? So let's look at that a little bit more. All right. And that's the correct answer, by the way. Urinary loss with bicarbonaturia, I will show you. So first of all, this is an old study where they looked at electrolyte concentration from gastric fluid in normal subjects. And what you're seeing here is the cations and anions in gastric fluid after giving histamine. And so the potassium is that hatched segment of the bar. That's the potassium. And what you're seeing is that the potassium in emesis is very low, say, just like serum, maybe 3 or 4 milliequivalents per liter. And so to get a potassium, and remember, when you see a low potassium, as you know, that reflects a very substantial loss in potassium because there's so much potassium in cells that when the potassium goes down, you could simply release from cells to remedy that. So once you see a potassium in the 3 range, we're talking about 1 to 200 milliequivalents deficit, depending, of course, on body size. So the notion that you could get a loss in a low potassium from the vomit itself proves to be not the case because there's just not a lot of potassium in vomit. All right, now remember that normally, and I showed you a picture of the proximal tubule earlier, when the bicarbonate goes over a threshold, then it can be simply excreted, okay? So normally bicarbonate, as it increases, it is readily filtered and goes out. Okay, and so this would be the idea that proximal reclamation is equivalent until you get it to about 24, and then you end up excreting bicarbonate. Now, when bicarbonate goes out in the urine, it doesn't go out alone, okay? It goes out with a cation, and that cation would be sodium or potassium. So in individuals who have chronic vomiting, say an individual with bulimia who has chronic vomiting, they are going to lose sodium and potassium with the excess bicarbonate when they are not volume depleted. Okay, so this is generation, both from when you have the losses of HCl, and you can maintain the pH by simply dumping extra bicarbonate with a sodium or a potassium. Although over time, that can contribute to potassium losses and to volume losses as well. Okay, so that, and let me just go back and make sure we got all those choices. So urinary loss with bicarbonate causes chronic K loss in an individual with chronic vomiting, all right? And I'm going to get to secondary hyperaldosteronism in a moment, actually a little bit later. Okay, so let's do this next question. This is I think it's a 68-year-old man who is evaluated for management of hypertension. He has also long-standing hyponatremia. He takes hydrochlorothiazide, lisinopril, carbamazepine for a distant history of a seizure disorder, and he doesn't want to stop that. On exam, his blood pressure is 150/88, and he has no edema. He's not willing to stop that carbamazepine. A trial off of the hydrochlorothiazide does not improve his serum sodium. And I have this in bold. This is not in your syllabus. His urine osm is 600 milliosm per liter. Which of the following is the next best intervention for this patient? Okay. A, restart the hydrochlorothiazide because we're trying to manage his hypertension. B, change that hydrochlorothiazide to chlorthalidone. C, begin torsemide. D, add amlodipine. Or E, start tolvaptan. Okay. Okay, so most of you would do what I would recommend, which is C, beginning torsemide. And so it is true that we want to address this patient's blood pressure, and it is nice to have a diuretic. But I think that with torsemide, you can sort of kill two birds with one stone because it's a longer acting diuretic, although we've been told that it doesn't, that loop diuretics are not good for hypertension. Some of that may be related to their short duration, whereas torsemide is longer acting. Amlodipine would not help us with the hyponatremia, and tolvaptan is a little bit problematic. I know we have the reps here, but it's just so expensive and would not address the hypertension. So let's think a little bit more about hyponatremia, and I know you're going to have some great talks on that later. But here's the thing. In order to make a maximally concentrated urine, you need two things, okay? You need to maintain the concentration of the medulla, and of course you need activity of vasopressin. So if the medulla is not concentrated, then you won't be able to maximally concentrate your urine. So I love torsemide for treating patients with SIADH who have evidence of hypertension because, as you know, the medulla achieves its concentration with the help of the loop of Henle. So as you go up the thick ascending limb, it's impermeable to water, and you're taking out sodium, potassium, and chloride. And so the fluid in the lumen is becoming more dilute as you go up, but that's making the medulla concentrated, and that's why we call it the concentrating segment. So if you block that, then you cannot maximally concentrate the medulla. And then when ADH has its effect, you won't be able to make urine that's 600 milliosms per liter or per kilo. You'll only be able to make urine that's about 300, which is much, much easier to manage in a patient with SIADH. So I love this strategy. It's generic, it's cheap, You can use furosemide, but it's very short acting, so you'd have to give it over and over and over again for SIADH or for hypertension. So this is a great strategy for a patient with SIADH and hypertension, I think better than, in my opinion, salt tablets. And so that's why I recommend it. You can use tolvaptan, but that comes with its own can of worms I'm sure you'll hear about later, because patients will have very significant polyuria, and then they will have to drink water and can get into trouble in the other direction. And plus, it's so incredibly expensive. Many patients' insurance will not cover it, and it gets very, very tricky. Patients have to be instructed about whether or not they can drink a lot of water or not, based on how their urine looks, and I just think you're asking for trouble. So I think torcemide's a better choice. So you remember that the loop diuretics work on the sodium potassium 2-chloride cotransporter and lead to losses of sodium, water, and also potassium, probably because of distal delivery. Okay, so question 7, sort of on the same theme. A 45-year-old woman with lithium-induced nephrogenic diabetes insipidus is seen in follow-up. She has stopped lithium, but she's had no improvement in her symptoms, and she would like additional therapy. You recommend a high-solute diet, the use of a thiazide, increased fluid intake, or amiloride. Okay. Here we go. So I'm seeing a mixture of thiazide and amiloride. All right. So this patient is no longer taking lithium. All right. They've stopped lithium. And the way that amiloride has been purported to work is that it would block the uptake of lithium. Remember, lithium's right under sodium on the periodic table. They're pretty similar in size. And lithium can enter the kidney, enter the principal cells via the epithelial sodium channel. And so by blocking that with amiloride, you would decrease lithium entry into those cells. But at this point, when nephrogenic DI is established and the patient's not taking lithium anymore, that may not have particular benefits. That might offset potassium losses, but alone, it would be unexpected that that would help significantly. And the other thing people don't remember is that lithium can actually go into every tubular cell that has a sodium transporter, not just the principal cells. And so, although this would offset the problem with nephrogenic DI in the principal cells, if you were thinking about lithium's toxicity to the kidney, then amiloride alone would not help you as well. So use of a thiazide then was a desired answer. So let's think about the distal convoluted tubule for a second. So thiazides I liken to sort of the Inspector Clouseau of diuretics. Like they get the job done, but there's quite a bit of collateral damage. So remember that thiazides work in the distal convoluted tubule. And this is where we make our most dilute urine. So the initial filtrate is the same. So if the normal serum osms is 285, the initial filtrate, 285. Then as you go through the proximal tubule, you have isoosmotic reabsorption. So at the end of the proximal tubule, you're still at 285. You go down deep into the loop and you make your very concentrated urine, let's say 800 to 1200. That 1200 is for kiddies because I haven't seen one over 1,000 yet. If I have pediatric nephrology friends here, I bet you have, but I have not seen that yet. So you get really concentrated urine in the lumen of the loop. And then as you go up the loop, as I said earlier, you take solute out, but impermeable to water. And by the time you get to, say, the top of the loop, you again have 285. Now you get to the distal convoluted tubule where we maximally dilute urine. And so they're still impermeable to water, taking sodium and chloride out of the lumen and making that very dilute urine, 50 to 100. Okay, now if no ADH is around, that dilute urine can go out. Okay, if there is ADH around normally, then you can reabsorb more water depending on the concentration of the medulla and the amount of ADH. So thiazides, therefore, would interfere with dilution. So let's see. Okay, so they work there. And by blocking sodium and chloride, they limit the ability to maximally dilute urine. So if you have somebody with nephrogenic DI and you give them a thiazide, they can't make that 50 to 100. And so they'll put out more urine that is less dilute. I have tried this in many a patient with lithium. And if you don't remember that urine flow is going to be very high and that their potassium loss is going to be significant, they're going to stop it before you can even check the potassium. So if you're going to prescribe this, either give them a Miloride also, or give them another K-sparing diuretic, or give them potassium, because this is going to be a problem. This is a favorite board question, but I think it doesn't work that well. I don't know what your experience has been. This is a favorite board question, doesn't work that well. Okay. Blocking sodium chloride reabsorption there also leads to an increase in calcium reabsorption, another favorite board question. We have learned that this is because when you block sodium chloride cotransporter on the distal convoluted tubule, that would favor the electrochemical activity of a calcium transporter in the distal convoluted tubule. That might be true, but it turns out that when you block this transporter, you get mild volume depletion, and then you get an increase in calcium reabsorption proximally. We know this because if you knock out that calcium transporter in the distal convoluted tubule in the thiazide-sensitive cells, you still get the increase in calcium proximally and a decrease in the urine calcium. So probably doesn't work the way we were taught, but it still works. And this we use, of course, all the time for treating hypercalciuria. And I know you're going to have a great talk with Dr. Curhan later today. Also, that increased distal loss of sodium leads to potassium losses. And so you get hypokalemia. And then it also leads to hydrogen losses. And so a mild metabolic alkalosis. And then the mild volume depletion that I mentioned leads to proximal reabsorption of bicarbonate, so the generation of the alkalosis from the losses of chloride here, and then maintenance because of reabsorption of bicarbonate proximally, and then finally reabsorbing other things there too, like uric acid, and we get some gout. Okay. So the patient who has the nephrogenic diabetes insipidus, you can try the thiazide diuretics. And the other incorrect answer was the sodium intake. You would like them to have a low sodium diet if possible so that they don't have to have an obligate loss of water with that sodium. Okay, question 8. A 6-month-old infant is brought to the hospital for lethargy and malaise. His mother reports that he has not been nursing normally for the past few days and he's been irritable. Diaper changing, however, has been normal. On exam, his temperature is 102. He has dry mucous membranes. Phlebotomy was very difficult, and the serum sodium turns out to be 158 with a urine osmolarity of 120. So, which of the following is most likely? A, congenital nephrogenic diabetes insipidus. B, surreptitious use of hypertonic formula. C, a thirst defect. And D, a reset osmostat secondary to fever. Okay. Okay, great. So this little kitty has developed hypernatremia, perhaps because of the fever and insensible losses, and then the inability to nurse. And yet, this kitty is still wetting the diaper normally. And then we find out that the serum sodium is very, very high. So that's a very potent stimulus for ADH. And ADH should be on, and yet the urine osmolarity is quite low at 120, a very poor response to ADH. And so this is nephrogenic diabetes insipidus, that's congenital. And that's why unlikely to be the use of hypertonic saline, hypertonic formula, because then the urine should still be very concentrated. If there's a thirst defect, the urine should still be very concentrated. And that's why those are incorrect. And then the reset osmostat story has to do with hyponatremia. And I'm not sure that I believe it that much, but it doesn't concern hypernatremia. So that's why A is the best answer, congenital nephrogenic diabetes insipidus. This is actually a patient of mine I inherited from Mike Summers, who's going to talk later in the course. Now he's grown up and he has children. But this is how he presented. And mommy was a new mommy, and she said, boy, to the pediatrician, oh my gosh, I have to change the diaper all the time. He's always nursing. He's always filling the diaper. The pediatrician said, of course, you're a new mommy. That's what it's like. And then it turned out that it was a little more, because the baby kept making a lot of urine even when he had developed hypernatremia. So now he's grown up and he has actually 2 boys. And this is X-linked. So it's done. Anyway. And that has been rewarding for me. So you know that when ADH is not present or not functional, you make a large volume of dilute urine. And when ADH is present, a small volume of concentrated urine. There we go. And so this gentleman I do have on a thiazide and a milleride, and he's on, he drinks a lot of water a day, maybe 13 liters or so, 10 to 13 liters, and tries to follow a low, he's not very good at it, but a low sodium diet. Oops. And this is just a pretty cool picture of principal cells. The arrows on the top are aquaporins when vasopressin is present, and on the bottom, when vasopressin is not present, fewer aquaporins. So you know that when vasopressin activates the V2 receptor on the principal cells, that deploys aquaporins to the luminal membrane, and then these aquaporins, and it enforces that they stay there. And these aquaporins are these really incredible water channels for which Peter Agri won the Nobel Prize. The water sort of goes through, and then midway through changes direction. I think that's pretty cool. And I like them. And there have been several defects that have been described in the vasopressin receptor, and these cause congenital nephrogenic diabetes insipidus. It's pretty uncommon, but very rewarding to treat these patients. Okay. Next question. We're going back to our student. Remember the one who was vomiting, who had hypokalemia? And I invoked early losses of potassium with bicarbonaturia. Well, that poor student is still vomiting, all right? And she's feeling poorly. She's back in the emergency room. Her blood pressure is 90/70. And recall her labs. Remember that her potassium was 3 and her bicarbonate was 30. She had generated an alkalosis. Creatinine was 1.3. And so here's this sort of evil up and down arrow question. Which of the following is most likely to represent her urine electrolytes? And I'm not going to read them. I'm just going to click go. And you can decide which is the most likely, okay? Okay, I'm going to stop. Let's see. Okay, I've got... I love it. Okay. All right, I'm just going to close this and let's look at it more carefully first. Well, I can just leave it here. So let's just talk it through, all right? Now, remember that early on, I told you that this patient would have bicarbonaturia with losses of sodium and potassium. So if you want to imagine the urine early, before volume depletion ensues, you could imagine that the urine pH would be high, okay, before volume depletion ensues, because remember that you would have that higher bicarbonate. And if you think about it, I like to liken it to the alkaline tide story. So remember that, let's say after a meal, you secrete more HCl into the lumen of your stomach. And when you put H into the lumen of the stomach, you're putting a bicarbonate into the blood. And transiently, there's a little more bicarbonate in the blood. And then once that comes to the glomeruli, you just dump that bicarbonate. And we call that the alkaline tide. And you may have observed this in your clinic. When I see patients at 1 o'clock, it's very common that those patients may have a urine pH that's like on the higher side, could be 6.5, could be 7, because they've had their meal. And then my 2 o'clock patients, their urine pH may be 5. And so we see that very commonly. And so that early scenario, if that's happening sort of all the time, where you're not volume depleted and you would just dump a little bit of extra bicarbonate, maybe it could even be 7.5 transiently and back down. And then urine pH goes back down. And I love this because I think it's really cool. The notion that the urine pH might go sort of up and down through the day when you're eating. And that's really handy because some things are soluble in alkaline urine, some things are soluble in acid urine, so if they could be changing, maybe you could be sort of washing out some sort of subclinical crystals. I don't know. Sorry, I'm just having so much fun up here. Thank you. So anyhow, so early, we could imagine that the bicarbonate might be high. And with that bicarbonate, the sodium might have been high, the potassium might have been high, and the urine chloride, she's vomiting, would have been low. Now, when volume depletion ensues, okay, now the urine, so remember that now you should reclaim all that bicarbonate. And so because you're reclaiming bicarbonate, the urine pH should be low. And some have called this the paradoxical aciduria. It's not a paradox to you because you would not allow that bicarbonate to go out because you're going to reclaim bicarbonate with sodium in the proximal tubule. And so the sodium's going to be low, the pH is going to be low. And now, because there's very little distal delivery of sodium, the potassium is going to be low. And they're vomiting, so the chloride's low. So some have called this electrolyte poor urine. Poor urine. And so that is why the desired answer then should be, let me close this. This one here, B, because everything is down, okay? So again, here's bicarbonate coming into the proximal tubule and being reabsorbed with the help of the sodium hydrogen exchanger. And it turns out that angiotensin II, remember I said, works throughout the nephron to help you reabsorb sodium, and it actually stimulates the sodium hydrogen exchanger to work harder. So you're going to reabsorb more than that normal filtered load of bicarbonate at 24. You're going to go for broke and reabsorb a lot more, if not all of that sodium with bicarbonate. And that will be your maintenance of alkalosis. Here's the so now here in the distal nephron, we have that cobblestone. We have these cool intercalated cells with the principal cells, and they work together. They're really close together. And so the milieu for the two of them is the same. And so you know that the principal cells reabsorb sodium, make the lumen negative, and that favors loss of potassium here in the intercalated cell, okay? but it depends on distal delivery. And that is what we have historically called the aldosterone paradox. Why aldosterone seems to be sometimes a sodium retaining hormone and sometimes a potassium secreting hormone. And we've attributed that to distal delivery. And it turns out that's not the only story. It turns out that when aldosterone is turned on because of angiotensin II, angiotensin II also affects phosphorylation here of the mineralocorticoid receptor. And so then what happens is that you do not secrete potassium when aldosterone was turned on because of Ang2. And so that explains why all our patients with hypotension don't get hypokalemic, right? Because otherwise that would be a problem if they got hypokalemic because of volume depletion. So that's the answer. So that's why the one with K high when sodium was low is not desired. Okay, and then you could fill this in on your own. I'd love to do one more question. I'm running out of time. Okay? Okay, this is the last question. An 8-year-old boy is seen for evaluation of delayed growth. His blood pressure 100/60, heart rate 96. Screening labs are done because he's not growing. And you can see here his potassium is 2.8, bicarbonate is 12. B1 and creatinine are there. Serum calcium 9.9. A urine pH is 6.5. Urine protein to creatinine ratio is 0.1. Urine calcium is 0.3. And what is the most likely cause of this patient's laboratory abnormalities? A, hypocalcemic hypercalciuria. B, the classic distal RTA. C, Gittleman syndrome. And D, chronic diarrhea. Okay, I'm going to not give you as much time because I talk too much. Okay, so this kitty has severe hypokalemia, as you can see, and also the bicarbonate's very low, suggesting a metabolic acidosis, and it really can't be a compensation for respiratory alkalosis when it's this low. So this is a metabolic acidosis, there's no gap, and severe hypokalemia, all right? And then I noticed that in spite of the metabolic acidosis, the urine pH is not maximally acid at 6.5. And then I also note that hypercalcemia, so that hypercalciuria, which threw some of you off. This is the classic distal RTA. It's not Gittleman's because Gittleman's causes a metabolic alkalosis. And I don't think it could be chronic diarrhea because the urine pH should be lower then. So we have to blame the kidney. And so this is the classic distal RTA. And because of the severe acidosis, these kitties use their bones as buffer. And they may have then increase in calcium load. And that contributes to their risk of kidney stones. And so just to remind yourselves, here's the collecting duct, and we have those two cells that I showed you sharing the same milieu. And normally, if ENaC works, you make the lumen negative, and that will lead to loss of both potassium and hydrogen. So if a transporter here is not working, let's just imagine that you can't, let's say it's this transporter, and you can't maximally dilute your urine. You can't get rid of hydrogen. The lumen's still negative, and now potassium losses will be profound. And so that's what you're seeing here. And then because you can't maximally acidify your urine, we're seeing that urine pH that's not as low as it should be, and we're seeing that metabolic acidosis. So when you see two defects, both the hydrogen and potassium, you should hone in on the distal portion of the kidney. And this is depicted here. So I'll end with the urine cartoon I promised, and I just want to thank you for your kind attention.